All right, thank you everyone for putting your suggestions into the group. You are almost universally spot on. Thank you for that. That means we honestly have a lot less to teach than we expected, which is great. So we're gonna get started now. Kristen, if you could forward the slide.
Sorry, I was still looking at the Q&A.
It's okay. So I'm Megan Honick. I am an independent community health and curriculum specialist in Rochester, New York. I work with different agencies and groups around the city on issues like health literacy, on sexual health, on trauma-informed care. And I've been in the field for about 12 years.
My name is Kristen McKay. I am currently working as a project coordinator and capacity building assistance coordinator at the Center for Community Practice at the University of Rochester here in Rochester, New York. So I help basically HIV prevention providers to build their capacity, and I provide technical assistance to them to kind of increase and improve their services. I've been doing that just since January, and before that I was at a local community-based organization, and I was overseeing some grant-funded educational programs for people who are living with HIV. And I've been in the field of public health and specifically in HIV prevention services for about 20 years now.
So today we're going to be talking to you about stigma, and our objectives are going to be that hopefully when everyone leaves here, they'll be able to define and describe stigma in their own words, identify the ways that stigma impacts a patient's ability to access and engage in healthcare services, define person-first language, and identify stigmatizing language and offer person-first alternatives. So by no means are we saying through this that person-first language is the only stigma intervention, but that it is one that works especially well in healthcare, especially around policy and publications. We want to be able to refer to people the way that they would like to be referred to, and especially in respectful ways, regardless of what we're putting out there. So first, we're going to define stigma. The dictionary defines stigma as a mark of disgrace or infamy, a sign of severe censure or condemnation, regarded as a person who is, or regarded as impressed upon a person or thing. It's a brand. It's something that marks someone as different, as lesser. The sociological definition is that it is the phenomenon where a person or individuals are taken to be different in some way and are rejected by the greater society in which they live based on that difference. So labels that associate people with unfavorable or disapproved behavior and characteristics. So it's not always something a person does, a person is, a person decides to do. It's sometimes something that they have been just labeled by the outside, not necessarily something that they would wear themselves. So stigma is actually a cycle, but it's also a structure. So we're gonna go from kind of the structural standpoint to looking more at that cycle and how it actually functions. So we start off with the bottom of the pyramid because that's what's supporting everything. So the structure is gonna be things like institutions, so schools, the police and law enforcement, and healthcare. So the way that these organizations are built are often intentionally built to leave some people out. And then also unintentionally. That is something that we see over and over again, is that people are left out, maybe not because of anyone's ill intent, but because there's a lack of representation within focus groups, a lack of representation on boards and maybe patient committees. And those things just get passed on because they seem natural to the people who are making policy and who are founding these organizations, whereas they might not necessarily be something that other people resonate with. So next up is going to be interpersonal. So whereas the structures were these big, vast organizations and agencies, we're going to be looking at interpersonal as between two people or more people, and it's going to be between stigmatized and non-stigmatized individuals. So the person who is stigmatized, maybe going into a healthcare setting and seeing their doctor or the front office staff, or interacting with a police officer or with their teacher at school or a guidance counselor. And the way that those interactions are impacted are going to be significant depending on the power differential there. And we'll talk about power again in a few minutes. And then there's the individual's interaction with stigma. And so that can be concealment. So a person might not disclose a health status, their gender identity. They may not talk about their family if they live in a family that people might not consider conventional. And so those things are things that a person might keep to themselves, and they might feel self-stigma and shame about. So internalized homophobia is a factor in self-stigma, but we're also going to be talking about things like a person dreading going to the doctor because they don't want to be weighed, because they know that that will result in a conversation that has previously made them feel uncomfortable. And so while this is a structure, it also reinforces itself. So the structures at the bottom promote interpersonal interactions that are stigmatizing, which promote the individual to, again, think of themselves in that stigmatized way, and it loops back down. So then seeing stigma as a cycle in society is a little bit different. This is how it actually develops within a culture, and it shows that it's not necessarily something that a person is doing intentionally, but something that exists as a process and that we all engage in some way, shape, or form, and maybe aren't aware of it, but can become aware and work on. So when we're talking about labeling, we're talking about saying there's a difference here. There's a difference between me and this other person. And labeling can be really awesome because we can say, you know, you have a difference from me, and we can celebrate that. Whereas when we then take it that next step into stereotyping, we're associating that label with differences and negative characteristics with those differences. So a way that people might do that is to say, you know, all people with mental illness are dangerous or unpredictable. When we originally started doing this as people, it was really adaptive. We were doing this because there's a predator and we want to associate all those predators with danger, and we want to be able to sort our thoughts that way. We think of things, we categorize them, and then we make generalizations about the category. And that was really helpful with plants and animals that could kill us. But then today, when we're trying to give someone healthcare, it's not so effective. And we want to be a little more aware of what are the thoughts and what are those assumptions going on behind what we're doing, and how are they impacting the way that this person is receiving care. So the next step is going to be division. And this is a logical step after stereotyping. It's where we say, you know, this group is linked to all of these negative things. So maybe I don't want them so close to me. Maybe I don't want them around me. We'll hear this a lot, like, you know, I don't have a problem with so-and-so, but I wouldn't want them to watch my kids or live in my building. And those are those types of messages that are division. And we have to be aware of the way that we use language to divide in order to use language to bring people together instead. So at its worst, division through language is dehumanizing, things that are used to justify some of the inequality that we see today. So we need to be aware when we're saying things and what we're saying and how that is used to separate groups rather than highlight and celebrate difference, because this is where the cycle starts to become dangerous and harmful to people. Labeling and stereotyping, you could even make some people will make the case that there are positive stereotypes. I would make the argument otherwise. But once we get past stereotyping, we're really into the more harmful aspects of the stigma cycle. So when we get down to loss of social status, this division is used to justify it. So not only are they maybe not people we want around us and not people that we think the best of, but whatever the group is, maybe they don't deserve the same opportunities that other people do. Maybe they don't deserve the same supports and the same structures that keep them in power as other people do. So it determines where a person fits on a hierarchy. It determines the types of chances they're going to have for success and improvement. It determines how quickly their ideas are listened to and accepted by others. And it also is determines how often they're going to be like interrupted or talked over by other people. And then with loss of social status, this message repeatedly that they're not as important, we see discrimination, and discrimination takes a lot of different forms. I think we tend to think of legal discrimination as like the main idea, but it's also things like less funding going to a stigmatized disease because it is seen as less important or less wholesome and less worthy of that money. Or it can be who's going to get hired on a set of applications based on, what does their name sound like? It can be political action. It can be violence against the group or person. It can be not listening and not engaging and not involving. And it can be speaking speaking over or against that group or person. So I definitely want to take some suggestions from our group chat and talk about how those do or don't fit into the cycle. And I'm going to give one of my own that doesn't. But let's take a look at one of these. I'm going to pick one to go through. So in here, I saw a couple, and I think the one I'm going to pick first is people who are transgender, so trans folks. So by simply labeling a person as trans and saying that, this is a trans individual, we're not necessarily doing any harm. We're saying this is a person, this is their identity. But by stereotyping, and one that I've heard in healthcare is that, oh, well, all our trans patients are so sensitive. They overreact to everything. And at that point, if you know that a patient's coming in and you're thinking, well, I know that they're trans and I know that trans people always overreact, it's easy to say that maybe I don't want to be as friendly and open and inviting as I normally am. This results in loss of social status. They're not as welcome in the clinic. They don't feel the same way and they aren't treated the same way as other patients. And that's discrimination, that they no longer have that same access to healthcare as anybody else. And so when we get down to it and we really look at the system, we're finding out that maybe trans patients are defensive, maybe trans patients are anxious, and maybe they're frustrated because when they walk into a healthcare setting, they're often called by their dead name. And that's going to be triggering for a lot of people, just as any other repeated action is going to be triggering for anyone else. So we really want to be aware of what is actually going on behind the cycle, and regardless of if there's a cause or not engage in furthering the cycle. So let's go with one that works, and then I'll pick one that doesn't. I love the person who said only one or two and then gave several. Thank you. Let's use people who use injection drugs. So by saying that a person uses injection drugs, we're labeling an activity. We're not giving an identity to the person. We're not saying that this is who they are and all they are. But once we stereotype and say, well, that person uses drugs and drug users, they're all the same, then we've got a problem. And we're saying that, well, they're all thieves or they're all violent. And that results in that division that, well, those are negative things that I don't want in my life and I don't want around me, which results in that loss of social status. So they might not have access to housing in a particular area or might get removed from their housing based on use. There might be doctors who refuse them healthcare because they aren't able to stop using at this time, which results in discrimination. They might be over-arrested or targeted by police. There can be violence against people who use drugs. There's a lot of verbal abuse, limiting access to services in different areas. And we want to be aware of that, and that, again, labeling that difference didn't cause a problem. It was when we started attributing negative things to it that we did, and that the people started to have these negative outcomes. And so we are going to see, with people who use injection drugs, higher rates of untreated abscesses, poor nutrition. We're going to see people who are really delaying preventive care. And we want to decrease those by making people feel more welcome and accepted and engaged in their own care. And if we're providing non-stigmatizing care, we're going to increase the chances of that happening, of them being okay engaging with us. So lastly, one that doesn't work. So I'm going to choose a group that I think we're all familiar with, hopefully, men. So men don't necessarily fall into this cycle for a couple reasons. So I can label people as, you know, this is a group and they are men. That's a difference. We're okay there. But then I get into stereotyping. I say men are all aggressive and loud and they all drink beer. Okay, I've put some stereotypes on it. But then, do we really have division? Are there places in our world that men are not allowed to go? And for the most part, no. There are ladies' nights where men are charged more than women to enter a bar. There are bathrooms that they are not allowed in. So we could make an argument, yes, there's division. But is there loss of social status? No. There are no real rules around, like, men can't hold these jobs. There aren't any assumptions that men can't do this work for the most part. Men more and more get into fields that were typically feminine, and eventually it becomes acceptable, even if there are some struggles along that way. And there isn't really discrimination in the sense of laws regulating men's bodies and where they're allowed to be and how they're allowed to act and access healthcare or education services. So we want to be aware where these things fall off. And the last component in why it doesn't work is that objectively, in our culture, men have more power, both institutionally and structurally. So the fact that they are on the higher end of the power spectrum and they're going to have the more power in any of these interactions means that they're not really going to be a victim of stigma because of their masculinity. There might be other factors and identities that they carry with them that are stigmatized, but maleness isn't one of them.
Megan, we have a great question in the Q&A that I think deserves a live answer in the moment here. So someone said, how about the opposite, like being overly nice to someone from a stigmatized group? Could that be seen as patronizing?
I think definitely. And I think that sometimes members of non-stigmatized groups might really struggle with that because we're like, all right, I care so much about making you feel accepted that maybe we would put too much out there and we try to overdo it, and it can come off as condescending. So really, I think just promoting really just authenticity in yourself and really coming from, you know, your best intent is going to be the absolute best thing you can ever do. And if it comes off like that, I've actually found that explaining, like, I'm trying really hard to be affirming, I'm trying really hard to be accepting and to make you feel welcomed, and I'm sorry if that came off as condescending. Is there anything I can do? And engaging in a conversation with the person that, you know, what would make you feel more comfortable? I had a client for a while who had an interaction with another staff member where they finally came up with a deal because she felt condescended to when the staff member would greet her with this cheery hey every time they saw her. And so what they ended up coming up with was that the client would start conversation, would start that interaction. And then from there, the staff member didn't feel like she was guessing, would the client like to hear from me today? Would they like to be engaged? Or are they going to feel like they're being targeted or like sought out? And so that's something that you can put into effect, is kind of talking about what makes you feel comfortable as an individual, because no matter what we come up with today, we're not going to be able to tell you something that's going to be true of every single person in a group. Like, it's just not going to happen, which is unfortunate, but also a reality.
We also have a few other comments, and we just have a minute or two left in this section, so I think it'd be great if you want to talk to that a little bit. So someone said, when you were discussing men and how they fit in, don't fit into the stigma cycle, someone specified white men. And then someone else said, you're assuming men includes all men regardless of race or ethnicity. We can't ignore interconnectivity of race and gender. And then somewhat related, folks are kind of bringing up the idea that there can be bias about perhaps like single dads staying home, no changing tables in men's bathrooms, men accessing mental health care, men showing emotion, accessing mental health care. It's an underserved group. So,
Definitely.
Yeah, I think if you can talk a little bit about the intersectionality of race and gender, and then kind of that bias that we might see.
So definitely. So bias still exists regardless of if a person is a member of a stigmatized group or not, especially because bias is usually acted by smaller groups or individuals. So for example, if there's a woman who says that, you know, she doesn't really like men, they make her uncomfortable. That's probably coming from personal experience, and that's affecting things. But it's not necessarily discrimination or causing men to lose social status because she doesn't have the power to do that on a mass scale. And I do agree definitely that there are huge disparities between the way that men can access healthcare versus women. But again, that's not a form of discrimination so much as just a mode of gender roles and how people interface with healthcare as a whole, because men don't access preventive care at the same rate as women. But it's not because there's things that aren't taken into account, like childcare or like personal safety, or sorry, I'm struggling here. But no, I think they're both good things to bring up. And then the intersectionality issue, definitely. We are not made of one identity. There's no way that you can describe any single person in terms of one identity. But to talk about stigma, that's how we have to break it down for individual roles. But then we can layer that, and we can talk about how, yes, there is going to be a very different experience for a white man than for a Black man. And that being a man will impact a person's perception of the Black man's Blackness in a way that it doesn't interact necessarily between whiteness and masculinity. And so we need to be aware of that, and we need to be able to talk about those connections. But just for a very simple discussion of stigma in terms of healthcare, we kind of have to break it down into just one identity at a time. Does that make sense?
I think it does, and I think you made some great points, and I think, you know, the one thing that, scroll through the slides. Okay, one thing that is kind of sticking out to me in this conversation is really the difference between stigma and stereotyping, or stigma and bias, right? So, and I think it really goes back to that power differential, right? So, you know, thinking about men in healthcare, in mental health care, right? So yes, there are some biases, there are some stereotypes, there are some kind of preconceived notions that we have in American society about men being stoic and men not talking about their emotions and men not having issues with that. But there really isn't any like structural, if we think back to that pyramid, right? There's no structural problems in the idea of a man literally not having access to go to a mental health site, or kind of not having the resources to be able to get there. And again, back to that intersectionality idea, of course, that doesn't apply universally to every single man in the United States. Certainly, when we're talking about, you know, race, we're talking about other marginalized communities that certainly contain men, then yes, those things do exist. But on the whole, it's not because there is a structure in place that prevents men from receiving the same kind of care or services that a woman or a female identified person would necessarily have. Anything else on that, Megan?
Nope. And then obviously for trans and non-binary folks, it's going to be a whole different set of issues. It really is such a nuanced and varied way of talking about things that in practical use, the stigma cycle doesn't work. This is more of a theoretical model of how stigma functions in a society, but it's not necessarily helpful to think about it in a single individual's day-to-day life so much as on a whole as a general rule.
Definitely, that makes sense. Great, okay, we will move right along. See, you got a preview of some of these slides. So we're gonna move into talking specifically about how stigma plays out in healthcare. And I think now that we understand what stigma is and where it comes from and how power plays into all that, we'll be able to kind of see the consequences of how that plays out again in healthcare specifically. So as I'm sure most of you know, stigma can have some pretty dire consequences for patients. So these are just a few of the negative outcomes that can occur as a result of stigma being present in healthcare. So they might include delayed access to care. So stigmatized groups tend to avoid care or delay it as long as possible, like Megan was talking about. And that can lead to delayed diagnosis and misdiagnosis in a lot of folks. Stigma can, of course, lead to poor patient-provider relationships and a negative outlook about chances of recovery. And this is actually seen both among providers and patients. So they kind of have a more negative outlook or even consider kind of a more negative prognosis for patients if they are members of a stigmatized group. Early termination of treatment is also more common for members of stigmatized groups, and they tend to receive poor physical care. And there's an over-reliance on self-treatment, meaning that providers tend to under-prescribe medical intervention even when it's warranted if that person or that patient is a member of a stigmatized group. This is another way to kind of look at the health consequences of stigma. So if we start at the top of the diagram, we can see that stigma leads to poor health services, access and uptake, harassment and abuse, discrimination and violence, which then lead to marginalization. Marginalization is really that idea of keeping someone in a powerless or an unimportant position within a society or within a group, and they're treated as insignificant or peripheral. Marginalization, if we go back to the diagram, then leads to poor social emotional well-being, poverty, and risky situations and behaviors, which all lead directly to sickness. Even without marginalization, poor health services, access and uptake can lead to poor social or emotional well-being, leading to sickness. And violence can lead directly to risky situations and behaviors, which then also lead to sickness. So I want to give you a brief example. So if we think about Mariah is a transgender woman. She's been unemployed for the past 6 months because she was fired from her position as a sales clerk at the mall. It was supposedly for missing cash from the cash drawer, but it ironically coincided with her supervisor finding out that she's trans. She hasn't been able to get hired for another position, even though she applies to at least 3 jobs a week. She spent almost all of her savings now, and she doesn't have health insurance, so she just has to hope that she doesn't get sick. She has a friend who turns tricks, and she says the money is good. Mariah is thinking that might be her only option at this point. But what if she gets an STD? Before she resorts to that, she decides she'll try the Unemployment Services Agency one more time. When she arrives, the receptionist calls her by her dead name, and the job coach says she has to put her legal name on all of her job applications. She leaves without getting any help, and that week she doesn't apply for any jobs because she feels defeated and hopeless. She stays at home in her apartment all week with the curtains closed to the outside world, and she stops eating. So we know that few providers or clinicians intend to stigmatize or discriminate against their patients. And even if we go back to that example with Mariah, the job coach, the receptionist, most likely didn't go into work that day thinking, I'm going to, enact stigmatizing behavior to the people that I work with today. But it can kind of go wrong very quickly from a lack of knowledge or awareness. So again, most providers have best intentions to provide good care, but take this short vignette for an example. Day. A hospital room with two patients, Annette, who is Black, and Linda, who is white. A white nurse enters the room, putting on gloves as she enters. She approaches Annette. Nurse, here are your meds, honey. She hands Annette a small cup with pills in it. She removes her gloves. As she walks past Linda's bed to leave the room, she pauses. Nurse, do you need anything while I'm here, dear? Linda, actually, yes. Can you adjust my pillow? Nurse adjusts Linda's pillows. End scene. So consider some rhetorical questions, and there's no need to answer these in the Q&A, but just think about them to yourself. How did the nurse exhibit stigmatizing behavior? Did she mean to? What might Annette have perceived? What might she have felt? Does Annette know what the nurse's intention was? How might this impact Annette's health? So we can probably agree that the nurse did not intend to exhibit stigmatizing behavior by wearing gloves with a Black patient and not wearing gloves with a white patient. She most likely didn't mean to unintentionally signal to Annette that she wasn't comfortable touching her without gloves. But there is no way for Annette to know the nurse's true intentions. If Annette perceives that the nurse treated her differently than her white roommate, she may develop feelings of distrust, anger, or even shame that could have significant impact on her health. These feelings could even extend to other providers on Annette's care team beyond just this one nurse. So the key takeaway from this simple example is that perception is reality. Even though the nurse probably didn't intend to mistreat Annette, if Annette perceived stigmatizing behavior, the results will be the same as if it was intentional. The defense, "but I didn't mean to," is insufficient to prevent those negative consequences. So next I want to share with you some statistics that really show and illustrate the impact of stigma in healthcare and make the case very clearly. As we do so, I'll also share with you some stigmatizing language that has traditionally been used with these groups and some less stigmatizing alternatives. And I do want to say there might be some offensive terms that you're going to hear me say and see on the slides. And these are being used purely for educational purposes and in acknowledgement that they are stigmatizing and they are problematic, and as a way to explain why and make the point that they should not be used anymore. First, let's take a look at sexual minority populations. So in the past, we might have used words like gays as a noun rather than an adjective. We might have said homosexuals or queer. With this one, I do want to note that some sexual minority populations have reclaimed the word queer, and they may identify themselves as such. So if a patient has explicitly used the term queer to describe themselves, then generally it's acceptable to use it. In general, less stigmatizing language includes using phrases like men who have sex with men, which we abbreviate to MSM, women who have sex with women, which we can abbreviate to WSW, and gay person or people. So note here the use of gay as an adjective, and it must always be followed by a noun to be kind of proper and to be less stigmatizing. In terms of kind of disparities that we see, studies have shown that sexual minority populations face considerable health disparities. So life expectancy was 12 years shorter in one study for sexual minorities who were living in communities that had high levels of anti-gay prejudice compared to communities with low levels of prejudice. So that's literally over a decade shaved off folks' lives because of prejudice. Among LGB adults in states that passed same-sex marriage bans, there was actually a 37% increase in mood disorders, a 42% increase in alcohol use disorders, and a 248% increase in generalized anxiety disorders. That's huge. And then after the legalization of same-sex marriage in Massachusetts, there was actually improvements in health. So 15% reduction in medical and mental health needs and costs, 14% reduction in depression, 18% reduction in hypertension. So we can definitely see that stigma and efforts to reduce that stigma have significant impacts on the health outcomes of sexual minority populations. We've talked about trans people a little bit already, so I think this is going to be a quicker, kind of easier thing to understand. But in terms of language, it's definitely key to always use the word transgender as an adjective and never a noun or a verb. So never, ever, ever, please never say a transgender, transgenders, or transgendered. Additionally, it's extremely offensive to refer to a human being as a he, she, or an it. It's also stigmatizing to use the incorrect pronoun or name for a transgender person, and every effort should be made to ensure the correct pronouns and name are used consistently. Less stigmatizing language includes always following transgender with a noun, like a person, like using person or people, so transgender person or people. Abbreviating transgender to trans is also acceptable, but I do want to mention that never should anybody be using the word tranny unless they are a person who identifies themselves as such. Again, correct pronouns and names are vitally important. In terms of statistics, they really show the degree to which stigma affects trans folks, although there is in general a significant lack of research on health outcomes for trans people, and actually just a lack of research on trans people in general. But that's a different conversation for a different day. We do know, however, from a 2015 study that among 6,000 trans people in the US, 28 experienced harassment in medical settings, 19% were refused care, and 2% actually experienced violence in their doctor's office. From the suggestions in the Q&A, I don't think this will come as a surprise to anyone here that communities of color do face some pretty significant discrimination and stigma in all aspects of society, and of course healthcare is no different. So first, just a reminder, we don't want to use words like ethnic, exotic, urban, inner city, thug, or ghetto. So we would prefer to use language that includes communities of color or people of color, although I do want to note that these terms are some also problematic in their own ways. So I'm using this in this presentation for kind of lack of a consensus on a improved or better term or phrase, but I do fully acknowledge that these terms are exclusionary and do leave out other populations. In terms of kind of disparities, studies show that racial and ethnic minorities that are exposed to discrimination were significantly more likely to experience panic attacks than folks who did not face or experience that discrimination. African Americans were 3 times as likely as whites to have experienced discrimination, and discrimination was associated with poor health. Among African American women, experienced racism was associated with greater distress, greater alcohol and cigarette consumption, more common colds, and more lifetime illness. And discrimination is associated with higher blood pressure among African Americans, Black immigrants, and Latino immigrants. I see that there are a couple people who have their hands raised. If you could just go ahead and type your question into the Q&A box. We're going to have a couple minutes in a very short time that we will answer those questions. So in this last section, we're going to talk just about some kind of practical tips and ways that you can consider your own language and your use of potentially stigmatizing and less stigmatizing language. So first, I just want to talk for a brief moment on person-first language. So you've heard us use some of that person-first language, and you yourselves have been using that. So people who use drugs, there's a couple other examples that are blanking out of my brain right now, but you know what they are. Person-first language is a way basically of speaking and writing that places the person before a descriptor or an identity or a diagnosis. Beyond this, person-first language should put the needs and wants of the person or the community first. So it should strive to be proactive as well as responsive to linguistic change. It's also called person-centered, respectful, constructive, humanizing, or inclusive language. So the goals of person-first language include to include people rather than alienate or offend, to respect personal preferences, to reduce stigma and the use of stigmatizing language, to be accurate and use more descriptive language, to prioritize the person over the diagnosis or the group membership, to cultivate self-awareness for the speaker, to be non-judgmental and non-biased, and to reduce power imbalances between patients and service providers. I do want to note that person-first language isn't always the way a person might self-identify, and that can be for a few reasons. So membership in certain groups kind of goes beyond a diagnosis or a shared quality, and instead represents an identity that holds value for that person. So by saying a person with, it can actually lessen the importance of that identity. So communities might form around stigmatized identities, and these communities and the individuals that belong to them may feel a pride in that identity, and using a label might be a way of reclaiming their power. Some identities are hard-won and carry with them inherited and social trauma, so it's important to be able to acknowledge this. So if we think of groups that might claim their stigmatized identity first, we might think about autistic people, deaf people, disabled people, fat people, or LGBTQ plus folks. Person first language might actually reinforce stigma in some cases if we only use it for stigmatized characteristics, because it can highlight that difference rather than equalize. This is because person first language is rarely used for what society sees as neutral or positive attributes. For example, we don't usually say people who do not use drugs in comparison to people who use drugs. Journal articles use person first language statistically more often for stigmatized identities versus non-stigmatized identities. There's also consideration to be given to the context in which the language is being used. Person first language should always be used when writing policies and publications, but may not always apply in more casual or spoken situations. Basically, the bottom line is that members of a stigmatized group get to decide what language is appropriate and what is not. And this again highlights the importance of kind of community relationships and inclusion of communities' voices. And last, we're just going to offer you some reflection questions that you can use to kind of think about your use of language in your practice. So the first one is the language that I'm using the language that this person or group would use about themselves? So for example, if I said, she seems a little over emotional about this, about a colleague, would that colleague use that same phrase for herself? Or might she say something more along the lines of, combating discrimination in healthcare is really important to me. It's a life or death issue in my community. I'm going to skip to the last example because we are running a little bit short on time, and I know there's a lot of great questions popping up, so I want to be able to get to at least a few of them. So the last one is risky behavior, and we use this phrase, right? And it was in a previous slide of mine, and we use it often as clinicians and providers, but it does imply some sort of blame or value judgment on an act, which for the person who is engaging in that act could be excellent, meaningful, profitable, exciting, normal, a variety of other kind of experiences. And I put condomless in there as a more accurate and less kind of judgy way to describe sex without a condom rather than calling it risky or unprotected. The second kind of reflection question is the language that I'm using something typically associated with a stigmatized group or community? For example, if we say something like, wow, that was crazy, do we really, are we implying something that we don't actually mean, right? We can really kind of reinforce some of those negative stereotypes, discrimination, stigma. And I can guarantee there's at least someone out there right now who's thinking, wait, can I just not say anything anymore? All words are, becoming PC or not PC, and there's word police and the whole thing, right? Let me stop you before you send me an angry chat message and just remind you that it is our responsibility as providers to learn about words and kind of address our old habits and learn new phrases, and they change. And so, one great example, I think if you're of my generation-ish, we all were able to stop using the word gay as a negative, right? We were able to stop saying that's so gay when we meant something we didn't like. So we can certainly grow and adapt and change as words and language evolves. One more kind of reflection questions: when I use these words, do I really mean something else? So for example, if we say I'm so OCD or ADD about this, when we're feeling disorganized or we're having trouble focusing, we can really kind of reduce the actual challenges that are faced by folks with these conditions, or we might reinforce the idea that regular or normal people don't have those labels. And the last one is just really thinking about, does my impact match my intent? And so thinking about, like, back to our nurse in this scenario, she didn't intend to act in a stigmatizing way towards her patient, but from a lack of knowledge or awareness, her impact was to cause shame, anger, distrust in her patient. And really what we're talking about is the fact that impact is greater than intent. So intent does matter, but impact is really where stigma lives and breeds and causes damage. Additionally, I just want to say that curiosity is not a good enough reason to ask someone a personal question if it isn't relevant to your interaction with them. So it's not the stigmatized person's job to educate us as providers. It's ours to educate ourselves. And there are plenty of resources out there, and we've included some great resources at the end of this presentation, and you should have the slides available to you as well from the website. So I do want to say, kind of in closing, that none of this conversation is about shaming or making anyone feel bad about themselves. We've all used stigmatizing language, and we've all, unintentionally engaged in stigmatizing behavior without meaning to. So it's a good way just to check our habits and challenge ourselves to always do better.
Yeah. Also, after our Q&A slides is a slide of resources and style guides that you will have access to that are all free to use and highly encouraged, and they will give you some options for up to date and then reasons why maybe a word has fallen out of favor. Obviously, language is always changing and in growth, so we're going to have times where maybe the document doesn't catch up as fast as we'd like it to, but it's also okay for us to make mistakes. We just need to be willing to learn and grow from that.
Great. And it's absolutely the last slide in the slide deck, so it's easy to find. All right,
and
Megan,
yes, we'll make them available.
Yep, I think they should already be on the website, but if they're not, let us know and we'll make sure those get out to you.
Yep.
And I see we're losing people because they're going to the next session, but we do still have a bunch of folks. So Megan, did you pull out any questions that you think we should talk about?
So we actually have been given a couple resources.
Awesome.
Which is actually really cool. One for Communicate for Health Justice. If nobody saw that in the ask, check it out. I will definitely be going. And so we don't have a handout, but our slides will be available, sorry, reading another thing. Thank you for everyone saying thank you. I don't have any specific information on evidence where older generation Latinx folks may have the same stigma being different from younger generations. I don't know about that. I think as views on racial justice changes, we're going to see slight changes, but I don't know that they're going to be so pronounced between two generations right now. Let's see what else.
I did see, I'm losing the comment now, but I
know they keep coming in.
I know. So somebody did mention the term BIPOC or BIPOC, so Black, Indigenous, people of color. And that has been used, and that's starting to kind of replace communities of color or people of color in a lot of cases. And it is a little bit more inclusive because it includes Indigenous populations, but it leaves out Asian folks, it leaves out Pacific Islanders, it leaves out a bunch of other communities that we definitely don't want to exclude. So my colleagues and I were just having this conversation on Friday, and at the moment, it feels kind of like we just really don't have a good term. And we just kind of, like I said, haven't really come to a consensus on what that should be and what kind of the most inclusive way to describe these populations is. One colleague who identifies himself as such suggested non-white. And so I thought that was really interesting. But then kind of the counter idea too is that are we implying that by being non-white, you're kind of out of the norm or abnormal, or there's some, that's kind of that negative idea. So again, I just think there's not a perfect answer to it right now. And I think the best that we can do is just kind of stay open and be flexible in our language. And if you're working with an individual, if you're working with a specific group of people, ask, or pay attention to the words that they use for themselves. And that might be different in different groups or with different people, but just kind of keeping that like flexible and adaptable attitude, I think is going to be what's best.
So something I wanted to touch on is, so one, the fact there is no perfect word use. I think the best way to do that in things like grant writing, because I did see that come up, would be to explicitly state what groups you are trying to reach out to. There were comments about like using marginalized groups. I think that can be fine depending on where you're putting who it is going to. But if you are trying to reach a group and be recognized as someone who's allying with the group, definitely putting it in explicit terms, who you are speaking to is going to be important. I also saw some questions about how to ask someone about their identity. And I think going back to that idea about, you know, why are we asking? If you're just meeting a person for the first time and their identity isn't relevant to what you're doing, say that we weren't talking about, you know, healthcare, but we were talking about like you're doing their taxes and they've already marked the box on their form, you know what that is, but like going into that conversation of like, where are you from? Not necessarily relevant to your interaction with them. So in healthcare, if it's not really fitting into the discussion, then it might not be the time to have it. However, just coming at it from best intent, so saying, you know, I want to be able to provide you the best services and care possible. I want to be able to link you to things that are culturally relevant. Can you give me any information on your background? What would you be interested in? Those can be really helpful questions without necessarily being like, you know, who are you and where are you from? Please tell me everything. So I also saw a question, Asians aren't considered POC. We were saying that Asian isn't included in Black Indigenous POC as that definition.
And it's POC, you're right. So Asians aren't included in POC, and that's sort of the problem. So when we talk about like, we talk about like people of color and we talk about white people, and we don't usually mention any other populations. And that's the problem, right? We don't have these terms that are, or a collection of terms even that describe everyone without unintentionally leaving folks out. Anything else, or should we wrap up? There was one that I wanted to respond to. Someone said blacks is extremely offensive as well. Yes. And I will say too, and we've mentioned this, both of us, a couple of times, that sometimes the language that we see in journals, in published content, or we use in presentations, and when we're talking about statistics, is very different than words that we would want to use in person with people, right? So we might see things like whites and blacks, certainly in journal articles, in the literature, right? And I know there was a couple of references that I used when I was talking about the stats that were much more in that vein. And certainly that would be more offensive if we were to be using that live with a person who's standing in front of us, right? And so that's something that we should be aware of too, and not kind of slip into using that language that we're reading and that we're seeing, that we're hearing all the time when we're actually interacting with people or patients or communities.
But also as we engage as providers of health services in whatever capacity we do, we also have the ability to start to include people more and more in the language that we use. So vetting things and having them go by focus groups whenever possible, so that members of the communities that they're intended for are actually seeing them, is going to be huge. Things like any of our advertisements or publications, we want those things to be reviewed and get feedback on them, rather than just throwing them out and saying that our idea of what these should look like is obviously the right one. So really having these discussions and having that involvement is always going to be key. And that's how we're going to be able to make better decisions about the words and the language we use, because we'll have involvement and we'll have shareholders, like stakeholders in it. So yeah.
All right. Well, I think we are almost at 3 o'clock. So I think we're going to be forced to sign off, even though I think we could both talk about this all day. Thank you so much, all of you, for all of your participation, for all the suggestions at the beginning, and all of your wonderful comments and questions. We really appreciate you spending your time with us this afternoon. And the conference organizers have asked us to remind you to fill out the evaluation. I'm not sure if it's going to pop up at the end or you're going to click on it kind of from the same place where you entered the session.
The second one.
The second one. So same place where you entered the session, the website, there should be a link to answer some questions just to see how today went.
Great, thank you. Everyone have a great day and enjoy the rest of the conference.
Thanks, everybody.